Thanks, Claire. Thanks, Perva and Mel and Martin for inviting me up here. It's a lovely part of the world, and it's a particularly nice day to be here. So normally when I give a talk, I try to give a focus to, impart some learning, something that, I want to share with you. With this talk, I hope I will impart some learning, but I think predominantly, I think it's an area for discussion, and I really want to raise some discussion points and perhaps give you something to go away and think about in your individual units. And it's certainly something that's caused my unit some anxiety. And I think there is an increasing emphasis on streamlined training. I'm not sure if any of you are aware, but there's a massive amount of discussion going on about standardising airway training in the UK, whether or not we should all be having the same drills and using the same bits of kit, all that sort of stuff. Nothing's come out of it yet, but I suspect within the next 5 years we'll have a much more standardised approach to airway training. And I wonder if the same discussion and the same process should be happening for training in epidural anaesthesia. So how to train an obstetric anaesthetist. So I've taken the liberty of adding a question mark onto this title because I'm not sure I'm necessarily going to give you the answers, but as I said, I want to just generate some discussion. Now, there are many components involved in obstetric anaesthesia. We don't just do epidurals and spinals. We also have to provide general anaesthesia, and that's been very topical over the last couple of years since the NAP5 report. Increasingly, our role is broadening on the labour ward in the same way that in our general anaesthetic practice, where we're moving towards becoming perioperative physicians. I wonder if on the labour ward, we're moving to becoming more peripartum physicians. As soon as anything goes wrong on the labour ward, we're called to look after these women. As well as that, we have to produce all the usual governance guidelines, training, management, all of those other things that we contribute to on labour ward. So actually training in obstetric anaesthesia is a huge topic, but the area I specifically want to focus on is how we train novice anaesthetists to competently perform epidural analgesia anaesthesia. And that's the particular thing that I think is causing a lot of anxiety and discussion at the moment. Now, how we used to do it. So a long time ago, over 20 years ago, I was the brand new anaesthetic SHO, as we were in those days. And I was quite interested in obstetrics, and I was told you have to do 30 epidurals before you even go to the labour ward. But of course, in those days, it was much more straightforward. We learnt epidurals in main theatres, and I remember hanging around after a few on-calls, and I knocked off 2 or 3 epidurals quite quickly over the course of the morning on an orthopaedic or a GI list. The patients were almost always asleep. I can't remember putting an epidural in an awake patient back then. And I'm pretty sure the consent process for me as a novice learning epidural was pretty sketchy. I suspect the patient was told, not consented in any way, that they were having an epidural, and they certainly weren't told, oh yes, the brand new novice anaesthetist is going to be doing this epidural. But of course, times have changed. We've seen a huge amount of changes in our working practice, enhanced recovery, minimally invasive surgery, shorter hospital stays, and increasingly epidural anaesthesia is not part of that surgical technique. And one of the components in Orthwick Park is we have St Mark's, which is a tertiary referral centre for major GI work. And increasingly, my colleagues who do these lists are doing single-shot spinals with huge doses of diamorphine. There seems to be a bit of a, let's push the dose of diamorphine up even further this week. But certainly we aren't using epidurals for post-op analgesia as in the same way we once did. There's an increased emphasis on patient safety. Now, is it unsafe to teach epidurals, to teach novices to do this? I think that's a dangerous ground if we start getting into that. But I do think that we're more cautious, and certainly part of the consent process, we're more likely, although not always, say, actually, this is going to be a very junior anaesthetist, or we're less likely to want that junior anaesthetist to do that epiduraling. If you're putting an epidural in these days, you're putting it in because you really feel you need it, and you really want to be certain it's going to work. And is that the right one to teach the novice on? And lastly, of course, we know we've had changes in the working patterns of junior doctors. So this is a widely quoted paper. It comes from Gordon Lyon's group. I don't know Dr. Searle. Do you know Dr. Searle? Are they still in this part of the world? People talk about it a lot, use it a lot to describe the difficulties associated with training in obstetric general anaesthesia. But I think you could just as easily insert the words opportunities and epidural, vanishing experience in training opportunities for obstetric epidural anaesthesia, because I do think we're slightly up against it in a way that we once were. Now, this is a quote from a review article about the use of epidural simulators. This group described an epidural as a complex amalgam of clinical judgment, technical skills, materials and equipment, drug delivery systems, and patient supervision. In addition to inherent complications in the procedure, each of these facets has the potential to generate human harm. As a consequence, an enormous number of injuries can occur. Now, if you were reading this as a novice, you'd say, right, I'm not doing epidurals, I'm going to be an intensivist, because I don't think anybody would want to take it on. But, so we know that epidurals are potentially one of the most difficult anaesthetic procedures to master. We know that they have a variable success rate. We know that there can be complications. But that we currently have no standardised approach to training in epidural analgesia or to competence. And I'm going to try and look at some of these aspects over the next 20 minutes. So most difficult and complications. How difficult is an epidural exactly? We all think it's quite difficult, but have we got any evidence to actually back up our perception? Well, this is quite an old but quite a nice study looking at anaesthetic trainees or anesthesiology trainees as they are in America, the recommended number of cases for anaesthetic procedures, and looking at a subjective assessment from these anesthesiology trainees about how they felt what was the most difficult procedure to learn. And they looked at spinals, epidurals, axillary blocks, intubation and art-line insertions. And they kept a diary over a one-year period, which was quite something to ask of anaesthetic trainees, I think. And what they found was that the anaesthetic trainees perceived that epidural anaesthesia was significantly more difficult than that intubation, insertion of an A-line, or brachial plexus block. They all felt it was the most difficult technique to master. Now, is there any evidence of increased complications? So this is some work that comes from Rachel Collis's group in Wales. I don't think they've ever published it as a paper, but it's an abstract from Ysoa from the annual meeting in 2007, so about 10 years old now. And there have been a couple of other abstracts in the last 10 years backing up this group's finding. And essentially what they found was a small but significant increase in the dural puncture rate. And the conclusions of this group was we need to focus on new methods of training in epidural insertion techniques if this current trend is to return to an acceptable level again. Now that's 10 years old. There's, as I said, been a couple of other abstracts with similar findings, and we still don't really have any streamlined approach to training. We certainly don't have any new techniques in training. So what is the aim of training? Well, the aim of training is to achieve this magical thing of competence. But I want to come back to that a bit later on. So what is competence? Well, it's the ability to do something successfully or efficiently. So really what we want to do is we want to maximize our success. We want to minimize the failure rate, and we also want to minimize the occurrence of complications. So effective training. So if we want to have effective training, I think we need to try and define success. And we need to look at, could we standardise the assessment of training, and can we standardise training in any way? So first of all, defining success. Well, whenever you want to define success, or what are the benchmarks, the gold standards we should be aiming for, we always look at the Royal College of Anaesthetists audit compendium. It's published back in 2012, and I'm pretty sure it's due for an update. In fact, I know they're talking about updating it, but it was such a huge amount of work, I think nobody can quite face taking it on. And in terms of epidural analgesia in labour, the benchmarks come from Perver's work with Ian Russell in Hull. And these are the standards that we use when we're auditing our unit practice for what represents success at epidural analgesia in labour. We should achieve adequate pain relief after 45 minutes in almost 90% of cases, an accidental dural puncture rate of less than 1%. We're all familiar with these endpoints of success. Now, these are incredibly useful statistics to use if you're looking at the practice of a unit. Whether or not they're as useful when you're actually training a novice to do epidurals is a bit more of a moot point. You're not going to, a trainee in their first 10 epidurals is not necessarily going to achieve those sorts of success rates. And certainly we had 2 trainees in my unit last year who both did 3 epidural punctures in the space of 2 weeks. It seems quite incredible, doesn't it? Especially when I was actually scrubbed and standing beside one of them. We were in quite a lot of trouble for those 2 weeks. So these audit compendium guidelines, it's how we measure the success of an individual unit, but not necessarily the success when we're training novices. Now, can we standardise assessment? Well, the thing that generates most discussion, is potentially most useful, is CUSUM analysis. So CUSUM analysis, cumulated sum, was originally used to look at the success of manufacturing techniques in the Second World War, when they were starting to have much more automated manufacturing techniques for technology, etc. And they wanted to look at whether or not they were producing items of an adequate standard and quality. So a CUSUM chart, which is the plot that you generally get when you're looking at CUSUM, is cumulated differences between successive values and a target value. And whenever you look at a CUSUM chart, you always want it to be going down. You want to see that line going downwards. It can often be used to identify changes in a process. Now, I know that Purva's done quite a lot of work looking at CUSUM analysis in epidurals, but this is the work that I think has been most recently published, but it has referenced Purva's work. And it comes from Rob Sneed's work down in the southwest. And what this group did was they looked at obstetric epidural data that was collected prospectively over a 15-year period, so quite a long time, I think. I mean, certainly in Norfolk Park, I think we might struggle to get all our data going back to 15 years. They defined acceptable and unacceptable success rates for epidural analgesia, and then they plotted CUSUM graphs for over 100 novice trainees over that time period. Now, this was their definition of epidural success or failure. The midwife assessment of the quality of analgesia throughout labour and delivery was anything other than good. So you know those iffy epidurals where she was mostly comfortable but she had a little bit of a patch somewhere? That wasn't good enough. It had to be absolutely good all the way through. If the woman presented for an operative delivery and the epidural didn't top up effectively and she had to have a spinal general, then that was a failure. And if there were any problems, such as dural puncture, that was also deemed to be a failure. So I think quite tough criteria, particularly the first one. Because we all know if you wander around an epidural, wander around a labour ward, and we've got 12 rooms at Northwick Park, some of your bigger units may have more, but if you've got epidurals in 10 of those rooms, you're very unlikely to have all 10 rooms which have got completely perfect analgesia. There's always going to be a couple of epidurals which are okay, but probably not at the recite point yet. But this is the criteria they did set, and they said the acceptable success rate, so to have this composite endpoint in 65% of cases. So it's not that high. You're only asking for 2/3 of your epidurals to meet these criteria. So what they found was that in this group of trainees, with a 65% acceptable success rate, the mean number of epidural attempts to reach competence was 46, which I think is a huge number of epidurals. You know, I work in a unit with almost 6,000 deliveries. We have an epidural rate of about, varies, but it's around about 60% for primips, about 40% for multips. But 46 is a lot of epidurals for one novice person to take on. But I think more interestingly, if you look at the range of numbers of epidurals that were required to reach this competence level went up to 114. Now, I'm pretty sure I spent a lot of time on labour ward. I do too much labour ward, and I'm pretty sure I didn't do 114 epidurals last year. If you push up your success rate, if you say, no, we want to do better than 65%, we want to aim for 8 out of 10 epidurals being really good, then your mean number of attempts to reach competence, it goes up to 77. And I think that's a lot of epidurals. Now, they did pick out they didn't name them, of course, the 5 trainees with the lowest overall success rates. And they did find some trainees that didn't become competent. Now, there was rather limited discussion about what you do about these trainees who don't become competent. And certainly, one of the problems about CUSUM is that if you use it as your standard, right, we say everyone's going to undergo CUSUM assessment, and if they don't reach competence, nobody has any answers about what to do with these trainees. And I think telling them, sorry, you're not good enough to be an obstetric anaesthetist, you'll have to be an intensivist, is probably not quite the right thing to do. one other point I want to make about this, I think, which is very useful with regards to using CUSUM analysis. This looked at the mean success rates for the first 100 attempted obstetric epidurals for 81 of their trainees. And what they found was that the first 10 attempts are absolutely crucial. So if you're going to concentrate on anything as a senior trainee or as a consultant who's teaching a novice, if you're going to do anything with them that's going to be really meaningful, I think it's giving them adequate guidance and supervision for those first 10 attempts and making sure their confidence isn't crushed with the first 10 attempts, because the first 10 attempts seem to be the most crucial in terms of getting them up that learning curve. Now, just want to mention one other thing about CUSUM. That paper generated quite a lot of interesting discussion, and there were lots of points that were highlighted, but one thing I do think is particularly relevant is that CUSUM looks at success or failure. It doesn't look at other aspects of an epidural procedure, such as procedural aspects such as maintaining an aseptic technique. And certainly, I was asked to go and supervise a novice, and they had a very patchy aseptic technique which would never have been picked up by CUSUM analysis. So if you're thinking about using CUSUM analysis in your units, and I don't think anyone's really talking about that yet, but just bear in mind it does have its failing. It's not completely the panacea to assessing competence that we might think on first perusal of it. Now, how can we standardise training? So I'm sorry about this slide. I had to quickly redraw it because we had IT problems. So I hope you can all see it. But this is, there's a really nice, in the Medical Journal of Australia, which is not a journal I normally pick up, but it's just something I found when I was flicking through. They have a really nice series of articles about learning things on the run. And this one was learning practical skills on the run. And this is what they describe as the stages in acquiring skills. First of all, you start off as unconsciously incompetent, and that's when you don't really know much about the technique and you're pretty incompetent at it. And then you move on to being consciously incompetent. So you know about epidurals or central lines or whatever technique you're doing it, but you're still pretty incompetent. But then you learn the technique and you become consciously competent. But that really describes a situation where you're having to concentrate pretty hard as you do it. And the point that we all want to aim to be at is unconsciously competent. So I would hope that I'm mostly unconsciously competent in terms of doing epidurals. But of course, as you get older, the anxiety is that you might slip back into being unconsciously incompetent. And I think as you get older, you certainly have to fight against that. Now, this is another article from Australia where they publish a lot about training aspects. I think in some ways we're kind of catching up with them. They've looked at this in much greater detail than us. And they found that the most common teaching method for epidurals is guided practical experience on patients provided by a senior registrar or consultant. And this is what they describe as a formal educational approach. So we think it's just, see one, do one, teach one, just scrubbing in with them. But there are actually steps that we could perhaps break down and use to assist us when we're teaching novices. So ensuring a cognitive knowledge base, demonstration of the technique, the trainer demonstrates at normal speed, deconstruction, the trainer demonstrates while describing the steps of the procedure, comprehension, the trainer demonstrates while the learner describes the steps. I think that might be technically difficult, slightly awkward sometimes on the label when you've got a very distressed patient. And lastly, performance. The learner demonstrates while the learner describes the steps. They're actually doing and describing what they're doing. Now, just looking at these in a little bit more detail, ensuring the cognitive knowledge base. I think that sometimes we're not as good at this as we should be, and certainly. And I think it's important to bear in mind there's a lot of changes to the medical school curriculum, and many junior doctors that are coming through won't have learnt their anatomy on cadavers. Their anatomy will have been squashed down and condensed. And certainly, despite spending a year in a small group with a cadaver when I was at medical school, my anatomy has always been, I would say, slightly suboptimal. So one thing that I do think is really important with novices coming through is that they make sure they have a really sound understanding of the anatomical basis of epidural analgesia. And actually, what we did recently was, which we found useful, just as a talking point, is we've actually got a spine out. We managed to dig one out from the anaesthetic department that was just sitting in a box getting dusty. And it's quite useful just to get trainees to look at it, to handle the spine, so they can really get it in their mind's eye, a 3D sense of where they need to put their epidural. I think another important aspect is that although I'm concentrating specifically on procedural aspects, a really important part, as we all know, is not just putting the 2E needle and then threading our epidural catheter. There's a huge amount of other elements that can contribute to failed epidurals. This is a really nice review article that summarises all those articles you've probably come across over the year. Mike Kinsella's article, Peter Pan's article from America. Those are widely quoted articles, and this review just summarises all of those in one article. So if you're going to look at one, look at this. And this article suggests that epidural failure rates can be as high as 40%. I have to say, I find that pretty anxiety-provoking, that the epidural, only 4 out of 10 epidurals that we put in are failing. I'll come back to this a little bit, but this is the areas that they talk about: technological reasons for failure and pharmacological reasons. And I think it's important that trainees understand exactly what they're doing and what they're aiming for, how things like catheter insertion and fixation can contribute to the success of failure, whether or not you're using bolus doses or continuous doses. If you are using bolus doses and you've got suboptimal analgesia, what sort of bolus doses can you use to improve the analgesia if the epidural is ineffective? And I think sometimes when we're teaching epidurals, we forget these other aspects that contribute to the success of epidurals. In terms of moving on to actual technical aspects, demonstration. I see in the, I was looking at the Brussels abstracts, the abstracts for the OAA meeting that are going to be presented, and I see Steve Yentis has got a poster that's been accepted. I can't remember the exact title of it, but it's something, so we took these to demonstrate to trainees that if you say to a trainee, pick up the 2E needle and hold it like this, everybody holds their 2E needles in a slightly different way, and everyone's got a slightly different technique for their loss of resistance manoeuvre. And I think that's often very, very difficult to explain to a trainee. Something that we found useful is we've got a simulator. I'll mention simulators in a little bit, but one of the most useful things about simulators is not so much the loss of resistance, but is actually getting them used to holding the 2E needle and the loss of resistance syringe, just so that they feel comfortable with it and they don't feel awkward with it, because it's much easier to do that on a simulator than on a moving patient on the labour ward. Now, can additional kit be useful? I think many of us have got ultrasound machines lurking on our labour wards. So could these help us when we're trying to teach novices? So this is old work now. It comes from Thomas Grau, who's one of the original guys who published widely on ultrasound in obstetrics, not just in obstetrics, but epidural analgesia in general. And he demonstrated that the learning curve for epidural anesthesia was better if you used ultrasound than if you didn't use ultrasound. People learnt more quickly to perform epidurals when they were using pre-procedural ultrasound. However, this is being contradicted by more recent work, and I would say that the jury's slightly out on this particular question. What I do think that epidural ultrasound can be useful is it can enhance your understanding of anatomy again. And I wax and wane about whether my enthusiasm for ultrasound. But one thing that I do think is useful is if you've got a woman presenting for elective cesarean section, just putting the ultrasound scanner on and just getting the trainee to look and just to try and understand the anatomy a little bit better. Whether or not it actually helps them then to perform that procedure, I'm much more ambivalent about, but I do think it enhances one's understanding of anatomy. Now, I mentioned simulators. Simulators, I think, are tricky, and I don't know if Perva's got anything to say about this at the end. But the ideal simulator, you really need realistic feel and forces. You need something that's going to, as closely as possible, recreate that sensation of going through the various layers you need to get to the epidural space. Ideally, you'd want a simulator that has variable characteristics. We know that all our obstetric patients, obesity is an increasing problem, but obstetric patients come in various shapes and sizes, but unfortunately simulators at the moment seem to be one shape and size. A simulator that you could use with ultrasound might be useful, but I think one of the biggest issues about just using simulators in your teaching laboratory is the absence of a realistic environment. You know, when we go to do epidurals on the labour ward, you've often got a very distressed, moving patient. You've got a lot of noise. You may have a husband or a partner who's very anxious and agitated also. lighting can be an issue. We've done a study looking at lighting levels in my hospital and all the lighting levels in this bid to try and make childbirth as lovely and Whale music-y as possible. We've got incredibly low lighting levels in all the labour ward rooms in my hospital. Certainly below health and safety recommendations. We're presenting that as an abstract at the OAA. And certainly last week I got a woman round from one of the rooms for emergency caesarean section. She's had an epidural sited by one of the really good trainees in the middle of the night. And the epidural had been a bit dodgy for the last couple of top-ups, so increasingly I found myself just pulling out epidurals that I'm not sure about, putting a single-shot spinal. So when I went to pull this epidural was sited at T1011, which is, I mean, she was a petite lady, she was even shorter than me, and but I said to the trainee, do you know where you put the epidural? And she said it was really dark, she was moving. But I think, you know, we don't often pay hindrance to the difficulties of the labour ward room, the environment that we work in. You know, it was the middle of the night, she was probably tired, the light was terrible, she was moving. The poor trainee was probably just desperate to try and get this epidural in anyway, although T1011 was probably a bit high. So simulators suffer from having an absence of many of these features. So what do we have in terms of available simulators? Well, I think you can, if you put any fruit into PubMed and look for it in association with having tried out as an epidural simulator, you can find it. This is what I think one of the nicest studies published in the European Journal of Anaesthesiology. They looked at, it was a blinded study assessing the feel of loss of resistance in 4 fruits: orange, banana, kiwi, and honeydew melon. I think it had to be honeydew melon. And then they scored these things on a visual analog scale. So which fruit do you think was the best at mimicking the loss of resistance technique? Anyone vote for orange? Yeah. Okay, any bananas? No. Kiwi? Kiwi's a bit hopeless. It's got really thin skin. Honeydew melon? Yeah. Oh, okay, right. No, so banana. The bananas have it. So if you're going to go to the greengrocers to get anything before you go to labour ward, go and get some bananas. So this, I mentioned this article at the beginning. This is Mike Wee from Poole. He's done and is still doing a huge amount of work looking at simulators in obstetrics. And this was a review that he published about 4 years ago now. It's a really nice review. And I think I can summarise this review in a few words. That he looked at 31 simulators, 16 that cover epidural alone, 9 that cover epidural and spinal, and 6 for spinal alone. So clearly there's no leader, there's nothing on the market that is really, wow, we should all be using this. And certainly the simulator we bought in my hospital, it's been very disappointing. Although it came with a pull-out back so that after you pronged it a few times you could replace it. Unfortunately, whatever it's made of gets lots and lots of leaks. So now as you're going in with your loss of resistance syringe, you're getting a sort of rainfall of water coming back at you. So I think I think simulators have their role, and I think in terms of demonstrating aspects such as holding and positioning yourself, but in terms of demonstrating that loss of resistance technique, I'm not so sure about. So what do trainees think? So this is a survey also done by Mike Wee's group, looking at trainees' perspectives of epidural training in the UK, and mostly it's quite reassuring, but I think it does give us some areas that, and some food for thought. 2/3 of trainees said that they found performing epidurals very stressful. 1/3 felt that they felt uncertain a lot of time. I mean, I think doing things for the first time or for the first few times is always anxiety-provoking, but I think you should at least have the confidence and feel certain about what you're actually doing. I think sort of more disappointingly, and I think somewhere where senior trainees and consultants can come in, is that about a quarter of trainees said they felt under considerable time pressure for midwives and ODPs. And I think just, you know, when midwives or ODPs are hassling trainees to try and do things more quickly, just remember all the times, you know, we've watched the surgical trainees sew up the really small wound over 45 minutes, and we've just sat there patiently while they've done it. So don't let midwives, ODPs, or anyone hassle our trainees. Now, I just want to finish off with a couple of points. So this is some work that it's a review looking at modern anaesthesia training. Is it good enough? From, I think it's Alistair McKinder from Bristol. And he did quite a lot of work looking at the impact of the European Working Time Directive. I don't even remember, but when the European Working Time Directive came in, there was a huge amount of anxiety about whether we could train our trainees adequately in the reduced working week. And the Temple report, John Temple, who was professor, I think, in Bristol, he was charged with actually looking at this on a national level. And he came up with a report with a series of recommendations about how we could ensure that we made training effective. But this is a statement that I particularly like, and I've kind of forgotten it, but I do try to remind myself of it now. And it hangs on this word, competence. This is the thing we're all aiming to get. We always want to get our trainees competent. And, whenever trainees come from one place, the first thing they say is, well, I want to get my competencies in A, B, and C, and I've got to do my neuro and cardiac at the Hammersmith. And everyone's aiming to get signed off and get their competencies signed off. That's what we're all aiming for. But actually, competence, just getting your competencies signed off is really, it's not the end of the journey, it's the start of the journey. The UK system focuses heavily on achieving competence in different areas of training. While this is clearly important, it understates the added value of consolidation experience based on repeated exposure. The establishment of competence should be viewed not as the end point, but rather as a stepping stone on the journey to proficiency and ultimately independent practice. So about a month ago, I was the consultant on call for the weekend, and it got to Sunday night, and our lovely trainee who's doing the obstetric block at the moment rang me and said, my baby's really sick, it's got temperature this year, and I want to take it to hospital with my wife. So I said, of course you must go. And I thought, well, that would be no problem, because Norfolk Park has loads of trainees at night. And I thought, well, I'll just have to reallocate the trainees. So that night we had 2 trainees on for theatre, one very junior trainee who wouldn't have been able to cover the late ward, but then we had a very senior trainee covering theatres, and then we had 2 senior trainees on for ITU covering 2 ITU fellows. So my initial plan was to either get the theatre senior trainee or one of the guys covering ITU to cover the labour ward, and I'd carry the additional bleep. Anyway, to cut a long story short, of the 3 senior trainees, all of them said we've had our obstetric competencies signed off, but we haven't done obstetrics for varying from 18 months to 2 years. Now, I don't know if I was just a mug or I was just gullible or I just felt guilty, I don't know what, but anyway, I ended up covering the labour ward that night because I was deemed to be the most competent, which I should find reassuring in some ways. But I just thought, gosh, it's a shame that we've got trainees, really experienced guys, and none of them wanted to be intensivists. They all wanted to be generalist anaesthetists, but they all said, well, I haven't done obstetrics for 18 months, I don't feel that comfortable about it. Now, at least, one of those trainees is applying for a consultant's job in a DGH, where they're going to cover theatres and obstetrics on call at night. And I think that... So I think my point is that if we only focus on achieving competence, if we just get these people signed off, you may not want to be an obstetric anaesthetist, but if you want to be something like a generalist, it's very likely that you're going to end up covering labour ward on call at night, if not during the day. And I think we need to, alongside competence, we probably need to add this word consolidation, competence and consolidation, if we're really going to aim to produce anaesthetists who are confident and competent across the board. The last point I just want to mention, the other thing, another aspect of this issue about consolidation is that, as we all know, as well as the science behind anaesthesia, not just epidural anaesthesia, but many aspects of anaesthesia, there's an art to it. And you get a greater understanding of the art, when to tweak the epidural, when to bail out and recite it, the more and more you see. So I think that's another reason that understanding the art as well as the science is another reason to really aim for consolidation as well as competence. So just to summarise, people learn epidurals and probably all techniques at different rates, and I think we must understand that. And when you allocate somebody for an obstetric block or a cardiac block or whatever block they're doing, that block may not be enough, and I think we must develop a greater understanding of that. We currently have no standard objective measure of competency in epidural analgesia. CUSUM is part of the way there, but it doesn't cover all aspects. We don't currently know the optimal training approach, and I do believe that we can do better. And I think that as I said, there's discussion going on about airway training, and I suspect the discussion will come for other aspects of anaesthesia training. But in the meantime, I think that at a local level, we can serve our novices and provide better training in epidural analgesia. Thank you.